Good afternoon and welcome. It is the May the 7th edition of the THCB Gang. I'm your host, Matthew Holt, the founder, publisher, guy who runs the healthcare blog and at Bog2Go on Twitter. And got a great group today, although one of them is coming later because affairs of state and radiology have intervened with Road Rat. But who do we have? Well, we have Kim Bellard, health plan marketing guru and late editor of the late and lamented Tincture, and now regular contributor to THCB. Grace Cordovano, enlightening results all the way from I was saying New Zealand, but I meant New Jersey. New Zealand would be more glamorous, Grace. But a patient advocate, board certified patient advocate. Later joining us will be Saurabh Jha, road rag radiologist from Pennsylvania. He's coming in a bit. Vince Kuraitis, from the wilds of Idaho, long-time healthcare and healthcare technology consultant, and Deven McGraw at Health Privacy. Deven used to be the government bureaucrat, now the entrepreneur citizen, and we're going to have her on come up. So here we all are. Afternoon, everyone. So I'm just going to go around the horn as we do and ask people what in the last week of the wilds of healthcare that they've noticed the most. So I'll start with you, Kim.
Well, it's got to be in our rush to reopen. There's no better metaphor than the president going to a mask factory and not wearing a mask.
And with Live and Let Die playing in the background.
Playing in the background, yeah.
Oh my God.
Fantastic. Grace, what do you notice in the last week?
So we're also seeing now patients are being encouraged to go to their appointments, to their screenings, to their routine care, especially if you have cancer and multiple comorbidities. And what we're seeing is that patients are using telemedicine. They're talking to their doctors. They're prepared for their appointments, and then they go, and they haven't been anywhere in 7 or 8 weeks now in northern New Jersey, and they go to their appointment. They're assured that they're safe, and they sit there for hours because it's so congested. There's no chairs for an infusion. The appointments are not coordinated properly. So instead of at minimum letting people sit in their car and calling them or texting them, we're not seeing any kind of appointment notification or wait time estimate. So people are just sitting there petrified, immune compromised, not really sure what they're being exposed to in a hotspot area.
So opening up is not being as successful as it might be. The V-shaped recovery of the healthcare system, not quite there yet.
We can do a lot better, I think, with simple communication.
Deven, tell us, come off mute and tell us what you seen in the last week. And don't tell us about your secret news. Tell us about more general stuff.
My secret news. Do I have secret news?
It's not that secret.
So, one thing that I have been seeing, I'd like to talk in a minute about the Citizen Patient Record Scorecard, which we released the latest version of last week. But what I'm seeing something that's been very interesting and curious to me, which is the use of HIPAA as a weapon by the conspiracy theorists around COVID-19. Like, if someone tries to make you wear a mask and you refuse to do so, and you try to say that you have a medical condition and that's why you shouldn't have to wear a mask or something like that, it's HIPAA, only spelled HIPPA. And HIPAA does not allow, information and credit reports, and HIPAA doesn't allow, it's sort of this very interesting combining of fields where, you sort of have HIPAA being the sort of privacy law that is frequently misunderstood, but has now been kind of grabbed by the alt-right as being the weapon against closures and face mask requirements related to COVID-19, which is the craziest thing I've ever heard.
Yeah, the combination of the anti-vax movement, the QAnon guys, and the Trump's conspiracy theorists, and the NRA, psychos is all coming. It's far too real. And speaking of people from that part of the world, Vince from Idaho, it is bunker. Now he's lost the ability to do the green screen. Vince, what do you notice this week?
Hey, well, I'm going to go take a different route. Last time I had the chance to join this illustrious group, my focus was really on the unknown around the data and the statistics that were coming out that were not clear to be how they should be interpreted. I think the observation I have today is we have a lot of known knowns that we're not doing, and it's not working very well. We know we need more testing. There's still massive shortages of equipment we had guidelines put out by the CDC, which I understand have been pretty much tossed, about the states and how they should be phasing socially coming out, and things are not headed the right direction. So as a result of that, what we've seen is two, I think, really remarkable and noteworthy studies come out in the last couple of days. One from the CDC data and the other from the University of Washington, but both essentially showing the picture of the number of cases and deaths more than doubling, and whereas the prediction had been that we would reach a plateau and then decline, or rather we would reach a peak and then decline, what we've seen is a plateau, and now the projections are showing that we're going to be going even higher in the number of cases. So we have known knowns. We're not doing what we know we need to be doing.
Yeah, and that comes back to Devin's point, right, about the conspiracy theorists. Well, I have for my sort of remarkable thing this week, the news has just come out about exactly how complete Keystone Cops, the entire approach of the federal task force headed by Kushner, and some of the states that logged in to acquire PPE was, and ventilators, including a Google employee who got given $69 million with the state of New York to buy ventilators and didn't have any. And then this remarkable story in ProPublica yesterday about a guy from, I think it was Alabama, who had a sort of blockchain company and somehow got involved in buying face masks and didn't have any face masks and was trying to buy them, and was flying around in a private jet to Chicago. I mean, the amazing stuff that's going on there leads you to really think that you do have a bunch of complete incompetence in charge. And the two things that could get me, just as we got on the air, the Justice Department decided it can't prosecute Michael Flynn, even though he pled guilty. That strikes me as being pretty incompetent.
And they have him on tape.
And have him on tape, right? But he pled guilty. And then we now hear that Jared Kushner is going to take over the vaccine task force. So, well, that's all cured and solved then, isn't it?
He solved the ventilator problem. He really can crack vaccines.
Yeah, so I mean, we do seem to be in this sense where there is still, incredible mixed messages from the administration about everything under the sun, testing, opening up, not opening up. Georgia should open up, then it shouldn't open up one day to the next. And you've got this incredible situation where you've got local states ganging together, the West Coast states, the East Coast states, to buy PPE and to try to figure this out. And you think, states coming together with an overarching authority. Don't we have one of those somewhere? Just apparently not.
Well, in Dakota was, Trump saying on Tuesday that he was going to disband the task force, and then the next day, I was surprised to find out that people actually think the task force is doing something useful. Okay, we'll keep it going. Like, there's no plan of any sort. I
mean, it's bizarre. So I wanted to get into impacts on the healthcare system, and a couple of things that I've noticed. One, I think we'll get into it a bit later, is the issue around, and we've touched this many times, the issue around financing and finances of the healthcare system. We'll dig into that in a minute. And the other one is particularly because we have Deven on today, access to data. So Deven, you've been at Citizen for 2 years now?
Yeah, almost 3.
Oh, wow, seems to be a long time. For those who don't know, you ran the Office of Civil Rights within HHS around sort of, and you spent your entire career looking at access to data and patient access to data rights. You know how to spell hippie. You probably even know what it means. Unlike 99.8% of people in health and health technology. And while you've been at Citizen, you put out a report the last year or so about the ability of you working on behalf of patients through Citizen, and you can tell people a bit more about what Citizen does to access data. And then you've just come out with a new report. So can you give the background to that report, what it does, how Citizen is working to help patients, and then tell us what's happened in the new report?
Sure. So when we first started, and this story is going to sound so familiar to Grace because she works with patients every day to try to get their data. But when we first started as a company, and we were trying to help our users get their data so that it would go in their Citizen profile. And again, remember, we're working with cancer patients, as Grace does too. They need way more data than you can get out of a portal. So just being able to plug in that records and other companies do to get portal data is not going to be enough for them. They need all of what they're entitled to under the HIPAA right of access. And we found very early on that it was really a slog. I literally was like, did I not write guidance on this? Apparently nobody cared. Nobody cared. It was a real humbling experience. But we decided, we took a page out of the quality measurement playbook and we said, what gets measured and publicly reported can get improved, and nobody was doing it. So we decided we were having enough of a sort of real on the ground experience with how hard it was to get records that we would start reporting on it, that we would evaluate how well providers were doing this, and then we would give them a score based on what HIPAA requires. It was a 1 to 4 stars. 4 stars is the highest for just pure HIPAA compliance with no hassle. And then a 5-star is actually if you're going above and beyond and not charging patients anything, even though you have the right to, and getting it to them within 5 days as opposed to 30 days. So the first report we put out in August, and it only had 51 providers on it. And we found that about 51% of providers were out of compliance with one or more provisions of the HIPAA privacy rule right of access, or they got into compliance, but because we dragged them there through multiple phone calls with supervisors and privacy officials to get records in compliance with the law. We also did a survey of about 3,000 institutions because we knew our denominator was too small to really make that much of a difference. And we found the analysis was comparable, like again, more than half of providers giving responses that would make them out of compliance with HIPAA. So we continued to build on the scorecard as we grew. And
can I interrupt you a second, Deb?
Sure.
Because I remember there are a couple of pretty big names who got either 1 stars or no stars. I recall Mayo Clinic, Stanford, a couple of others being, on the naughty list.
That the Mayo Clinic in one location got a 1 star, and in another location they got a 5.
Yeah, but the location that got the 5-star was the one in Florida, and the one that
or Arizona or something.
Wasn't there one in Minneapolis? So come on, so in Minnesota.
The one in Minneapolis, the
flagship,
the mothership was not.
Mothership Rochester did pretty badly.
Right, that's right.
Prior to John Halamka showing up there.
Well, exactly. Look, the idea of the scorecard was not to shame people. I recognize that there's some degree of
we like it, but it's shaming. I think it's shaming goes a long way, actually. But
yeah, well, but the whole idea was let's get this improved, right? So second scorecard, 210 providers on it, pretty much the same in analytics. Some improvement at the higher numbers in terms of more entities doing better, but we still had about 51% in the non-compliant with one or more aspects. Well, we put version 3 out last Wednesday, 820 providers, only 27% out of compliance. So it has dropped significantly. And more impressively, more than 2/3, 67% of all the providers on the scorecard, all 820 of them, got a 4-star or a 5-star. So seamless access and or doing better than HIPAA requires. And so that kind of exponential improvement really was not what we were expecting. We didn't think we would see it that fast. I think there's a number of factors to consider. Hopefully the scorecard is one of them, but OCR actually doing some enforcement. They've had 2 cases that they've settled. I think people realized they were serious about it. And then I think some of these new rules that are going to make access more automated in the near future, rules from ONC, rules from CMS, the information blocking rules also from ONC. It's just access is now front of mind. The huge emphasis that the federal government has placed on this, I think has helped entities to know that they had to go and look at their own processes and clean them up. I think, I'd love to hear from Grace about whether she's seeing any improvement in terms of her ability to get data for patients. I worry a little bit that the scorecard is not reflective of still what people are actually experiencing on the ground. But certainly we're seeing like an enormous improvement. And we were glad during a time when I think healthcare providers are feeling fairly beleaguered. Many of them are losing money hand over fist, that we were able to say something nice and good about what's going on out there. But I'm sort of very curious to see whether that our experience is echoed from across other domains in terms of people trying to get clinical record.
Devin, are the
Devin,
ratings?
just before we get Grace in here, can I, sorry, and then Kim, can I ask you, when was the data taken? So when was you've put out a bunch of these things now, relatively recently.
Yeah,
so
yeah, and
was
it's
the
all,
data?
every scorecard is cumulative. So, so from February 10th, 2019 to February 13th, 2020 is all of that data is on the scorecard. Everyone also gets scored on their last request. So for example, you mentioned earlier that there were some really big names who were 1-star scored in the early rounds. I think you'll see a different story for them if you take a look on the scorecard and check them out now. Most of them doing amazingly.
That's good to hear. Kim, was it quick? And then we go to Grace.
I was curious on whether, is the data based on people, on access to a patient's record that you've been involved with, or do you believe that this is what any patient at those organizations can expect to get going forward?
Well, I would hope the latter, Kim, but that's my concern is that it's maybe a little more of the former, because again, we've been at this for more than a year. Well, the scorecard hasn't been out for more than a year, but we certainly have been pounding on doors for records for more than a year now. And so we're becoming a little bit more of a known quantity, and people may be treating us better than they're treating other patients. I hope not. I mean, the whole idea was improve your processes, and we'll score you on our experience, but because that's what we know, that's what we can trust and objectively evaluate. But I have heard on at least a couple of occasions from folks that people that we gave high scores to did not treat them as well. And we take that seriously. And in fact, in those instances, we actually contacted the provider and said, you were really good to us. We gave you a 5-star. We just realized that your website says patients have to come in person to get their records. That's not compliant with HIPAA, and we're getting that fixed. So
that's good. So they're terrified of Deven McGraw, as they should be.
Well, I don't enforce the law anymore. I just make this little.
That may not slip out in the conversation. That, she's not at OCR anymore.
I'm not there.
That's great. Grace, can you give us your commentary on the state of play that you're seeing around records? I know you should tell people a bit more about unblocking healthcare and the stuff that you're doing there in this area as well.
So as an aside, I know I have previously said that I'm going to say when I get really frustrated, I'm going to say, that's it, I'm calling Deven, and that's going to be an open threat to any system that just does not want to work compliantly. I've said that on stage. I think it should be like a little bumper sticker, because I think the point is most people do want to do the right thing.
Yeah.
I think there's so much misunderstanding on HIPAA, on everyone right away immediately. At least from what I see, when patients or their families, a lot of the problem is when families come in and ask for a records request, if there's a language barrier, someone is just literally so sick, they can't get out of bed. And the daughter comes or the husband comes or a family friend comes, even though they're authorized, they're like, no, HIPAA, can't do it.
Yeah.
And it just doesn't work. And that's, so I think there's that fear component, but I think because of the work that Citizens doing, because of the people that are working hard in policy, and we are enforcing, there's fines that are going to be imposed. Policies are great, but if they're not enforced, people are paying attention and they do want to get these records. And people like Dr. Don Rucker, who are saying, digital app economy, and emphasizing, the administration has been emphasizing, this is the patient's right and patient access is the way. What am I seeing? I'm seeing a local facility here that's offering their latest innovation is curbside medical record pickup. And I don't even know what to say. And this is not middle of nowhere. I'm in northern New Jersey. I'm trying to find the silver lining that, yes, maybe you don't have to go inside, but we've spent $40 billion or invested or wasted, or however you want to frame it, in an electronic health record system. And I have to go to curbside pickup, and that's supposed to be the perk of the situation. What I'm seeing is that because of telemedicine, none of the major guidances or educational components emphasize that medical records need to be acquired in order to proactively prepare for telemedicine. Yeah. So what happens is, because now families are separated from their loved one who's their primary caregiver or care partner, they don't really know where their records are. So they're going to log into their portal and they're like, but none of that info is in there. So now what do I do? And then you have multiple comorbidities? Or how do you fill out an advanced directive when you don't have all the info? Or how do you do any telehealth consult with a new care team when you can't remember how to spell your diagnosis and your medications? So a simple prompt to tell people, all these vendors that have these telehealth solutions, if it's not baked into your solution that you're providing patient education, that this is not a nice to have, a must have, basic stuff, it's going to fail. It's not going to work because it's going to be frustrating. If you don't have a translator, if you don't have something for those that are disabled and you need accessibility, whether it's sign language or something to that extent, some type of an accessibility tool, it's going to fail. So I think we need to look through the lens of empathy, and we have a little bit of work to do still.
Yeah, I totally agree with that. But I think I'm hearing you say that, okay, we haven't got there on the electronic interchange that we talked about. We haven't really figured out the data movement part into the telehealth flow now that everyone's doing telehealth. But people are actually talking the talk if they're not walking the walk, which is a big change, even from a certain large EMR vendor, which came out against the ONC regs before. They were against it before they were for it, or whatever John Kerry would say. Or they for it before they were against it. Forget which way around he was. I'm thinking about government malfeasance with Katrina and doing a great heck of a job, Brownie, all that stuff. But even around those ONC regulations that Don Ruck has been banging his banging from his bully pulpit about, it took a long while to start to get hospitals and EMR vendors on board, but they seem to be getting closer. And I think that you're either you've caused it, Devin, or you're reflecting it in your findings.
So my 2 cents, I think what you're doing is really remarkable, Devin. So my hat's off to you and your company, for shining the light. I guess I'll be generous. We've been at this interoperability thing for a long time, and it's not going to happen overnight. What I see happening is, we're really building a network, and some of the nodes are not connected, and it's just going to take one at a time. And so glass half full, I guess, is my take here.
So I want to push a bit more on the. So go on, Kim.
We need a platform, right, Vince?
We need a platform. We need to connect all the different pieces, and it's not going to. But we're certainly moving in that direction.
So let's talk about possible platforms. I've been thinking a lot about this and doing some work in the background about this, which is I've been doing a lot of discussion and work with the telemedicine vendors who are opening up. We had Raj Agarwal on here last week from Jefferson talking about their massive increase in telemedicine use. And then I was talking with the folks who are working buried inside of MedStar, which is a big DC-based system. And MedStar's use of telemedicine is up 250 times, not 250%, 250 times. And this particular company is called Bluestream, which has got a sort of telemedicine system which allows, a network allows people to hop in and hop out, and has got, translators and English Sign Language and who knows what on that system, as well as, psychiatrists and this, that, and the other. I had Animal Health 2.0 a couple of years ago, so I know a bit about them. But they're kind of like, if you like, the new wave compared to the first generation of telemedicine, the Teladocs and the Amwells and those folks. What they've been doing, and I think some of these other companies are working at this as well, and I'll get to Epic in a second. What they've been doing is adding on to the ability to use the APIs, to use the FHIR standards, to go in and both take data out of and bring data into, take data out of the EMR, put it into the telehealth session, put stuff that's happened in the telehealth session back into the EMR, if that bridge has been made. But if they're working with a system that's got an EMR rather than just sort of independent telehealth company, telehealth consult, which doesn't have access to the data. But that kind of is getting somewhere towards the point that Grace was talking about. The other thing was worth noticing, and I noticed this today because their stock price went up by 50%, was there's a company called Twilio who are now working with Epic, and I think to see if Epic can integrate telemedicine into their system, kind of the way that eClinical Works has done with their Elo system, which has got telehealth as part of it. So I guess my question is, back to this idea of a platform and who's providing care where and who's in charge, and do we do chronic care in the home? I noticed that Livongo's stock was up basically another 20% today because they had great earnings because they're doing care for people in the home with diabetes. What does that platform start to look like? I'd love to get all of us have an opinion about this. What does that platform start to look like if we actually get some of these interfaces, the nodes on the network made, and kind of who's in charge and where a patient's going? So love any of you to riff on that.
Yeah, I'll start. I think what we've been missing in platform in healthcare, the comparison, first of all, to what we have in the rest of the world. We've got in the smartphone world 2 major platforms, Android and iOS, and 2 million apps each. And what we've got in healthcare is thousands of apps with no real platforms to connect to. So this is, again, not going to happen overnight. My take would be the layup is really for the EHR vendors. And you've been following this. You guys did a study, Matthew, with the California Healthcare Foundation. Are you guys doing that one again? Of how easy it is for the developers?
The study Vince is referring to is sort of look at the wider API access of the application programming interface access of the big EMR vendors for the little guys. We did it in 2016, we did it in 2018, and things were slowly getting better. Now we're working with Catalyst Health 2.0, which is the latest iteration of the Health 2.0 bit that Indu and I run. It's working with ONC to do a more specific survey that ONC is running this year, just more about FHIR itself, which is the sort of the emerging standard for those APIs. I think if we were to run it again, there would be it's somewhat similar to Deven's. It's the corollary of Deven's study, right? Which is how is it if you are a small tech vendor getting access to the APIs? In fact,
in the past, it's not been at all easy.
That's been very tough. So Deven, from the point of view of citizen, not what you do, but the techies, sort of, the guys who eat the pizza late at night and are building stuff. How are they? What would you say their answer would be compared to where they were 2 years ago?
In terms of the progress we've made on platforming healthcare?
Yeah, no, I mean, that was just not being the platform, but access to the APIs of the major vendors, how easy is it to plug into and get access to that data that way.
We're probably not, we decided fairly early on that we were not going to be dependent on that way of getting records for our users because the juice wasn't worth the squeeze. At the time, there was so little data available on the back end of these portals, and we're still, even in the 2+ years that it's going to take for the APIs and the more robust US CDI to be exposed to patient-facing apps through those APIs, we've got another 2 years plus 3 months before that gets enforced. So we're on that trajectory. We're getting there, but even with the expanded US CDI, you've got a lot of data that's not in. No images, no pathology reports, no genomic genetic test results. Depending on what kind of condition the patient has, it's not gonna be enough until we get to that point where this defined electronic health information, which is the entirety of the designated record set under HIPAA, which is what the patient has the right to, is the same thing as the US CDI. It matches all those rules around certification that require the vendors to make it easier for apps to be able to plug in, like none of them, like in effect for another 2 years. Information blocking will go into effect in November, but the certification rules will not go into effect for another 2+ years. So we're waiting once again for the nirvana that we thought we bought with $38 billion in high tech. Oh, well.
I like the fact that no one knows how much we spent, right? 30 billion, 32, 38, 45. It's like, how much did Kaiser spend on their Epic installation? 3, 8, 10, 12 billion. Who knows? I mean, but so if I was to get you as an N of 1, you get a citizen CTO on the line, you would say, yeah, it's okay, but it's not worth doing because what's behind the curtain isn't worth putting the curtain back for.
Today. That value proposition will change, obviously.
Although your boss there at Citizen was the guy who built the thing that Apple is now using to get access to all that stuff.
Yeah. I mean, before his sister got cancer.
When it didn't matter so much, it was just random people's
Well, and
electronic records. And now,
look, I mean, the ability for the average patient to get their data is still important. It's just the stakes are just so much higher when you're talking about people who are really sick, and the data needs accordingly are deeper. So,
all right, you broke up slightly at the end there, Deven, but you're saying the stakes are so much higher. People are really sick.
Information blocking, it sounds like.
yeah, no, the stakes are higher, and the data needs are deeper. Like, you know, we're contemplating is sort of the rules are heading in the right trajectory again towards meeting the needs of very sick people, but they're skewing more towards meeting the needs of healthier people at this point.
You know, I wanted to jump in. There's been a lot of red tape cut around HIPAA to benefit really more third parties to, in theory, help patients get the care that they need. But what I'm seeing is I'd love to squeeze HIPAA and the dates, that time frame of 30 days, tighter, because the reality is there's all different types of HIPAA requests. And I know I'm preaching to the choir, Deven, because you work in the oncology space. When your loved one or you get a cancer diagnosis, you're not waiting 30 days to get your records, because most specialists are so saturated with appointments for a particular diagnosis, because we're also specialized now. They won't accept a new patient unless they get a full copy of your records, basically justifying that you could be a potential candidate for them to review. So what in this pandemic where we have multiple comorbidities and COVID and all of these things and high risk cases that have now been pushed, I'd love to see HIPAA squeezed tighter, that turnaround time has to be tighter than 30 days, not, oh, we're because of HIPAA, you know, please be more patient with our records. We can't be, because in many cases, it's a matter of life and death.
Yeah, no, that was proposed, you know, so the Office for Civil Rights, the office where HIPAA policy and enforcement happens, right? They put out that request for information more than a year ago, asking for public comment on whether those timeframes ought to be shortened. But there's been no rule proposed, and they would have to propose a rule to change that first and get public comment on it before they could move to a final rule to actually change it. So but I wonder whether the information blocking rules will have some interplay there in terms of requiring people to have access sooner, where it's possible to do so and there's no sort of excuse that you can rest on in terms of those safe harbors around information blocking. It'll be interesting to sort of see how the OIG interprets slowness in providing data, even though it's compliant with HIPAA, but slower than it should be from an information blocking rule perspective.
Yeah, agreed.
if the OIG has their job by then I haven't been fired 15 times. This apparently seems to be the current way. Probably to be replaced by a dog, a Labrador breeder. I understand it's the new standard of access to HHS. Good job to HHS. Kim, you, I think, well, in the middle of this, we're about to make another comment about this platform issue. Maybe
to Vince's point, I think the EMR vendors it was theirs to lose, and I hope they lost it, because I don't think they're the right people for it. I really think you really want a health information company at the base that feeds all different sorts of other vendors, video, physician workflow, all the other things that come off of that. But they've proven that they don't really care about this in the same way that you would really want them to. So, you know, maybe it's a Microsoft, maybe it's a Citizen, maybe it's someone like that, but I'm not sure that we've seen that entity yet step forward. But I hope it's somebody new, not somebody old. You know,
the one to watch.
Sorry?
The one to watch, in my opinion, is what Google's doing with Project Nightingale. This is described on their blog, I think it was around last November, and it came out really fairly controversially when it was made known that they were getting all kinds of data from health systems that included patient information. But what Google's trying to do is essentially build a layer above the EHR that would pull from multiple EHRs, and in turn, once you've got that data collected, run algorithms on it to provide real-time information for clinicians about how patients should be treated. So, you know, if that were to be successful, it could be really disintermediating to the current EMR vendors. It would be a Google user interface, and you wouldn't necessarily need to interact with.
The thing that I always hated about high tech is it sort of oscillated the market in terms of the people that were market leaders, 10 years ago became even stronger, which I think, stymied a lot of innovation we should otherwise seen. I wish it, in retrospect, I wish we would have focused on what the goal is. This is what we want from physicians. This is the kind of data that we want to be able to report and so on. And you figure out how you get that to us, not, certifying systems that they're saying are doing the right sort of stuff.
Yeah, it was, we can go and sort of re-architect, reinvestigate and do archaeology on what happened. There are a lot of reasons going on into high tech, and there were a lot of good intentions, I think, as well as the need that we just needed to get ourselves to where, say, the Danes and the New Zealanders were, 10 years before in terms of their use of EMRs. So there was something ongoing there. I do think that we got something else going on as well now. You mentioned that sort of a technology company delivering an underlying infrastructure. So I've been, as I said, looking a lot at this. You've got telehealth out there. You've got these now people talking about doing remote monitoring with blood glucose monitors. And I mentioned Livongo and their stock price going up, and a bunch of other competitors in that space who are basically marrying the infrastructure that exists everywhere, Wi-Fi and Bluetooth and cell phones and what have you, plus specialized devices, whether it be blood glucose meters or blood pressure cuffs, or now pulse oximeters, because you've got this company Massimo, who've then seen their stock price and lost a bit, both in the hospital, and they have an outside hospital product, again, for doing pulse ox, which is a big deal for COVID, of course. And you've got to think about who is putting all that stuff together and who's at the other end of that. We've had this in the hospital, right, with the virtual ICUs and folks like Saurabh and his colleagues in bunkers looking at multiple ICUs. But now the idea is, do we start doing that at a mass scale? Do we start doing hospital at home at a mass scale, especially as people aren't showing up to the hospital anymore? And who is the entity that runs that? Is it an Optum, a health plan? Is it the VA? I don't know if we've even started thinking about answering that question. I don't know if the average big health system that's done what it's always done and has been tied into these big EMR vendors like the Epics and the Cerners has got the sort of DNA inside to go out and become a community-based health monitoring company that then does what Indu and I have called flips the stack. Starts with people being monitored, then gets them other services at home, and eventually gets them to a face-to-face visit if they need it, rather than starting with the face-to-face visit. But they're kind of being thrown into that right now, which is probably as good a moment as ever to welcome Saurabh. So welcome to the, I know you are busy doing some real work like you clinical folks do. So we have some fun stuff to talk about later, but for now, let me ask you, in the world you're sitting there in Philly and hospitals and Penn, what has been the sort of the thought about the changing infrastructure and the way that you're thinking about delivering care with so many patients now not in the hospital because they're not coming in for their routine visits, and thinking about delivering out there in the community? Do you think sort of the zeitgeist is ready to think about a big change here to go to this different kind of platform, or do you think things will be back to kind of normal sooner or later?
Well, I think there may very well be a change, a lingering change, but at the moment, everybody is recoiling to get back to the good old days. The volumes and everything else is what's on everybody's mind. Whether or not, tele will take off, it's hard to say. I think that, from the point of view of radiologists, many read from home, many don't, but the expectation will be that people will come and read from work, except when it's after hours in the evenings and night when you can read from home. So that bit hasn't really changed. So from our side, we always were a step ahead with distancing ourselves from the hospital as the need arose. The other specialties will be interesting to see how they continue forward, whether their appointments will be more and more tele than before, or will it just be a case of, thank God we can all now just meet face to face. I imagine tele will have some greater impact, but I don't think that it's going to get to COVID level. It'll be greater than pre-COVID level. But
yeah, that's kind of the question. Grace?
Saurabh, I have a question for you of something that I've seen in the past, but now it's popping up more and more with respect to telemedicine. So patient with cancer or perhaps a cardiology issue or maybe a stroke has imaging at a facility and then needs or has an emergency and needs a second opinion follow-up or is directed to a specialist. That specialist looks at the imaging and says, this is crummy, I don't like this, we're going to do it here in my facility. Now patients are trying to avoid at all costs going in to the clinic or anywhere, or they've lost their insurance because they've been laid off, they've lost their job, they've gone from 2 incomes to 1 or to no incomes. So patients are trying to use whatever imaging they have. Are you seeing patients use telemedicine to reach out to radiology directly to review any of the imaging and maybe plead their case, advocate to another doctor and say, hey, you know, this is quality imaging, this is what we're seeing, let's move forward with this, or this is beneficial enough to move forward with?
Patients very rarely communicate with radiologists.
Isn't that why you became a radiologist, so you could get away from the patient?
But that's changing slowly. So there's more radiology patient interaction. There are a bunch of second opinion companies that offer their services. They generally are taken up by clinicians who want to get a second read. But I'm told that some patients do approach them as well. But a bigger question is that how often do we end up repeating the imaging? When something is being done at an outside place. And I don't know if there's been a dramatic change in the last 6 weeks, but we often get asked to render a second opinion on an outside read. And it's now actually something that's billable, because I presume the insurers thought that it was cheaper paying for that service than for paying for another imaging study altogether. So we now actually do second reads, and we produce reports, and we look at the old report and say whether we agree or not. And we talk about the image quality. Most disagreements that happen are on the interpretation. Very rarely is it the imaging itself, unless they use a crummy MRI and we're not happy with that. But mostly it's just the interpretation. And you don't need a second acquisition just because of an interpretation difference.
Interesting to see what the difference are, what patients are told, and then coming from you.
Hey, Grace, can I ask you a question?
Sure.
You're in the epicenter, I mean, in New Jersey, and yesterday I think your governor announced another 30-day lockdown, and last we spoke, you were really cautious about going out. I think you were dealing with your mom, so I'm just curious what your on the ground perceptions are. And how are you doing personally? You look awfully composed given the world.
I look forward to these calls because I have to. It gives me self-care to prepare for the call. But it's scary. It's scary. Our governor has shut down schools for the rest of the academic year, and that is. As a scientist, I understand why. I get it. I know why we need to do it. As a mom, I'm so sad for my kids because they miss their friends, they miss their team, they miss their teachers, they miss their routines and being able to play and be a kid. There is a void there that no technology can fill. I don't care what remote learning you have. I don't care what modules. I don't care who you can connect with or what technology is available. Children miss what they're accustomed to. And then as a working mom, there's no end in sight. So it's overwhelming. So it's a very vicious cycle. But thank you for asking. I think the scarier thing is we do see the impact on the economy. Many small businesses are going under and are lifelines for their families. There's local businesses here who have been doing curbside pickup for different things, and they're being forced to shut down, whereas the local Target can do curbside pickup. So if I can buy a bike at Target, or if I want to buy it from the local small business, what's the difference? It's overwhelming. I like numbers and I like strategy and I like a well thought out plan. So this is a very frustrating place, but I'm also trained in aseptic technique. And I acknowledge, because of my colleagues in medicine, how tragic and the disaster this virus is. And we have no herd immunity, no medicine, no vaccine. So it's constantly walking the line of bringing credible information to families, local communities, my own family, being accused of being an alarmist, and a whole number of other synonyms that come with that, and being practical and not living in fear. So it's a very strange line to walk. I don't know what the right answer is. I do wish there was more testing. I'd love to get an antibody test to see if I had been exposed previously. Can't get that. Family members who have cancer and are high risk, who may have been exposed, who were very sick earlier in the year, can't get a test. I have colleagues in medicine who are still waiting for their antibody test. So
Wow.
I'm not sure how we move forward. And then what does it look like? Like, how do we bring families together? Kids need their grandparents. Kids need, like, just to like some kind of circle. Do they wear masks? Do they wear face shields? Should we be acquiring our own PPE? I mean, I get from an economy and business and virus transmission, but what about from like a life standpoint? How do we start bringing people together, teeny tiny bits? Can we?
Yeah, it's tough. I mean, I've been going out jogging wearing this, and it's not too bad. I can put it on for a bit, but I take it off when I'm like, I don't see anybody. But I do notice out in Northern California, about half the people are wearing masks, even though we're supposed to be doing that. We do have this, but now you've raised a point about, locking down a society, locking down a big city. Saurabh, you have to tell people what happened in London if they haven't heard the story. It's so good about the actual scientists involved.
It's a little bit of juicy gossip. Yeah, the what's his name? Neil Ferguson. What is it with people with a surname Ferguson, Matthew? They always get involved in scandals.
The
Usually.
historian, author?
No, he's this guy is the guy who ran the Imperial. He was he's an epidemiologist or some kind of scientist.
Epidemiologist ran the Imperial College thing.
The Imperial College study that initially was the one that convinced the British to go from let's just do herd immunity. Oh, whoops! Boris Johnson got sick, all the way to actually doing a lockdown and closing the pubs. All right, Rogan, you have to tell us what happened.
Yeah, so it's just hilarious. And so he resigned because I think news came out that he having an extramarital affair. I don't know if he's married, but he's having an affair with a married woman, and he broke the quarantine laws to see her. So a little bit of hypocrisy. And then, of course, it's obviously none of my business, and I just find these sort of things extremely hilarious because of the outrage that they cause. So people were on an outrage about the fact that he was a hypocrite, and he has one rule for everybody else, and because of him or because of his, and there's a lot of anger over here as well from people because of his dodgy model. Everybody else is actually home and quarantined, and he's out there frolicking. What's interesting, actually, the phrase "when the cat is away, the mice will play." Actually, it's quite the opposite in this situation. It's when the cat was at home that the mice played. I just thought that was very interesting. Quarantine kind of reverses everything else. It just changes all the rules. It's a shame that it came out this way, because you can imagine it being like a really a Hollywood movie with a lot of drama, modeler risking his life through the virus infested streets of London to see his lover, and they get caught, and they're both sick in hospital. Do they have coronavirus? And they're kept away from each other, and then they hug each other, or one of them gets it, the other one doesn't. So that's all been ruined by the Daily Mail. And innuendos on models and scandals. But I thought that was a nice little bit of light laughter for the coronavirus season.
I was most struck by the fact that he is about Ferguson's about as nerdy a bookish scientist as you could possibly find. He's not exactly Brad Pitt, and his lover or his girlfriend or whatever the term is who came around was this incredibly glamorous blonde woman. I thought he's striking one back for the nerdy scientists everywhere, but just not in the right way anyway.
Well, no, but you underestimate. Can you imagine the pickup line? My model caused Donald Trump to shit his pants. I mean, can you think can you think what kind of pickup line he would have with that? So I'm not surprised that
Maybe it was I got Boris Johnson hospitalized.
Well, Boris might not have been hospitalized, and mind you, talking about other scandal, Boris back in the UK, Boris, has the baby. Him and Elon Musk, in terms of people who you don't think has been responsible parents, both having yet another child. It's all happening. Although Boris has got a slightly more normal name than whatever the hell AE 12 15 to the power of 5 or whatever Elon Musk's new kid is called.
How do you pronounce that to kids' name?
Nobody knows. My Twitter feed has been full of people trying to figure it out. All right, let's just before we do our wrap up, we're getting to the side towards the end of the show. It's been a lot of fun. There is one thing I want to raise because it's starting to hit home even in tech world here out in Silicon Valley, is that today the unemployment numbers came out and they were absolutely terrible. They're clearly going to hit health insurance numbers. Literally yesterday, Airbnb, one of the great sort of unicorn success stories in Silicon Valley, laid off a third of its staff. Uber laid off a bunch of people. In my own household, my wife, I'm not sure it's public yet, but she's in HR and she's been working around the clock the last week because her company, which is a tech company, did a big layoff today. Strikes me is that even though the stock market is going up and some of the health tech companies who do remote stuff like the Teladocs and Livongos and Massimos are seeing their stock, go through the roof, and the stock market seems to be doing okay, that Main Street and employment is really going to be hurting for a while. So this has got to have impact on the quote unquote V-shaped recovery of getting back to normal, Saurabh, in terms of you talk about in terms of getting that elective care back. We know the health plans get paid in advance and have got a lot of money, and there's a lot of pent up demand for this. But I especially want to ask Kim and Vince to just push out, just in a couple of thoughts, push out 6 to 9 to 12 months. If we don't have this incredible new system that some people are calling for, in fact, George Albertson has a piece into me today, ex-Kaiser CEO, basically calling for Medicare for all via Medicare Advantage, essentially. Hasn't been published yet, but that's what it's about. What is your sense about where the health system that you guys look at every day is going to be in 6 months' time?
I'm sure it's scary times for them. You may have seen that United today announced they're going to start giving rebates to their customers now. And all the health plans, if they don't end up spending money this year because of all those underpayments, they're going to have to give that back due to the MLR requirements next year. They're going to have to give that back in rebates. So I think we're going from 40% increases next year to big rebates next year. But all that is money that's not going to the healthcare system to keep people afloat. So, the people that had to drop these elective procedures, Christy Farr has reported on the billions of dollars in losses some of these major health systems have had. You're going to see some bankruptcies, I think.
Vince, you've been looking at this a long time. What do you think?
The health plans are going to be okay, Matthew. You don't need to worry there.
I wasn't going to bed crying for like Stephen Helmsley and Larry Renfro, those guys. So they'll make it by.
I think we're really seeing we're on the cusp, just on the cusp of a huge shift, and you've got the supply and the demand side. Well, I think what's not being talked about so much is the demand side. People are going to be very cautious about going to restaurants and flying and going to see the doctor or not. And the whole notion of how health systems have been and doctors' offices have been built around locations and buildings and the capital that's flowed into that, that's changing and shifting. And it's going to take, again, I think years to see that, but I think we're not going. Saurabh, you referenced the hospital wanting to get back to normal. That's not going to happen. I think we're just on the beginning to see what kinds of new healthcare system that will be possible. The words digital first have been part of the vocabulary for many companies for a decade. They've never really been part of the vocabulary for healthcare, but I think that's about to change.
Yeah, you actually answered a question that Steve Woodell asked in the chat I hear, which was, our provider's going to have to go digital first. And, we don't have a lot of time to get into it now, but I think what I'm saying is telehealth going to come back the way it's stay the way it is under COVID, or is it going to sort of retrench back? How far is it going to retrench back? These are questions, and then who's going to be in charge, right? Who's going to be delivering these things? Because I would always argue that the current actors have not been very good at managing the process.
You mentioned, Matthew, you used the term hospital at home. My consulting work goes back over a couple of decades. That term is not new, and
Sure.
there have been projects in the U.S. Hopkins actually has piloted, and I'm trying to think of the name of the physician who's the head of that. But all the protocols, the infrastructure, the how to do that, has been piloted, and a lot of these pieces have already been tested. Now we just have to take them and operationalize them.
Yeah, I've actually written a piece about that, which I haven't, again, it's sitting in the queue. I'm doing a little bit of work with a company that's trying to get involved in this sort of at-home monitoring of the acutely sick post-COVID. You've got the people doing the chronically ill part, which is the Lobongos and the Martas and others of the world, and then you've got the people doing telehealth. And well, I'll wait. My prediction for next week will be we'll see some more action there.
I looked in my contacts. The name of the physician is Bruce Leff.
That's right.
From Hopkins, who's done all this work.
And there's a company called Medically Home out of Boston, which has been working on this with Tufts Health Plan and Atrius Medical Group. And we had about Health 2.0. But again, it's been teeny. It's been like a few patients here and there. We're talking about now potentially thousands and thousands of patients. All right, so we're at that time where I asked the gang what's going to happen next week. I assume so. I'll start. I'll ask you for just a couple of thoughts to sign off. Deven, what's your guess for what we're going to be talking about in the next week?
I knew you were going to go to me first.
Well, I mean, maybe you're going to release another report. I don't know.
No, we're not going to do another one for several more months. So next week will look a lot like this week. More and more information about how providers are suffering financially, more and more information about Congress considering yet another bill to try to prop up the economy. Maybe a little bit of indication of where some of these states that have opened up their economies, what impact that has had on their cases.
For a while. Kim, let me ask you about next week.
It scares me to death. We've gone from people protesting the stay-at-home to people with guns protesting to people now shooting people who are trying to enforce stay-at-home requirements. The security guard at Target, and I think there was one at McDonald's today or yesterday. Things are getting really crazy out there, and it's just going to get worse until. So on the one hand, we're going to let things off, and then the COVID's going to take off even more. So there's not a good solution coming out of this in the next few months.
Grace, what's your sense for the next week?
But we are seeing progress in science and research. There's more science and research and data being generated, and more findings and more understandings of the disease. We're seeing a number of different publications and reports indicating that there's significant increases in blood clotting in COVID positive patients, the potential role of anticoagulation in patients that are hospitalized. So I think we're going to continue seeing like a mind-boggling amount of work in trying for everyone working in collaboratively to get a better understanding and maybe create subcategories of patients. So we have, again, building a more robust toolkit as to how we're going to treat this until our vaccines, which a number of candidates did enter into phase 1 trials, start accruing more data so that we have evidence-based research that can guide decision-making.
Vince, your take on the next week.
Yeah. Grace, you described yourself as being alarmist. There was nothing alarmist in what you said. You were very optimistic there. So I'll take that role. I'm saddened. I see a lot of increasing politicization of the data and the tactics that we ought to be undertaking. And I'm really alarmed and worried about the future and how we are I'd like to see the scientists and the clinicians running the show, and it's not going in that direction.
Well, I mean, I would say the good news, and to interrupt before I get to Saurabh, the good news is that the polling on the whole shows that people are in favor of, what's been happening in terms of closing it down. Does mean it's a badge of honor to wear a gun and not wear a mask in certain extreme.
I hope you're right, Matthew.
And encouraged by coming from the bully pulpit in the White House. Saurabh, what do you think for the next week?
Yeah, the pressure to reopen is going to keep increasing, and it's going to come in various guises. The conflict here is the partial reopening, where you just allow certain things to open but not others. And I think that they're going to have to think of a way of partially reopening, because the pressure is going to mount significantly. And saw the scenes in Huntington's Beach last week. That wasn't a protest. Once New York starts getting more and more mobile, other states will ask as well. And at that point, you might get another spike. Let's see what happens.
Yeah, I think
like Vince, it's very hard to be optimistic.
Yeah, I think we're liable to have a second spike sometime, or at least big regional spikes. And if you look at the data, take out New York from the US data, the data is, the numbers are still heading up, and excess deaths over expected is still heading up. So I was talking about. So I'll end with one potential thing which is rather different, which is I think given some of the action in the stock market and given some of the things we've been discussing about the platforms, you're going to see, if not in the next week, and definitely the next month, a bunch of acquisitions people trying to put together this new platform play, and whether it comes from the health plans or comes from others. I think those people have been looking at, people are starting to get past the sort of scenario planning phase of what happens next. They're going to start making bets on when they have money about where there is some money, and some of these companies have done well in the stock market, about what do you need to put together to manage acutely ill people, chronically ill people out of the hospital, transitioning out of the hospital, and there'll be a data play in that. So it wouldn't surprise me if the Teladocs, the Bongos, and others of the world, maybe not next week, but in the next few weeks, start getting their checkbooks out and starting putting together for the bigger play. Because I think there is a very big play coming here, and the same thing's probably true for Anthem and Optum and maybe some of the bigger systems as well. So I'm on the healthcare business side and technology side, I'm looking for that to happen, because while the while the things are slowing down, the stock market is still going up. There are still deals in the world getting funded. Let's Get Checked got funded with $70 million to do at-home testing. So just this last week. So we're not at a dead stop, and people are starting to think about what that new world order might look like. So that's my thought for the next couple of weeks. And with that, I want to thank everyone. We're out of time here. We're joining me this week for the May the 7th episode of THCB Gang. I've had Kim Bellard, Grace Cordovano, Vince Kuraitis, Deven McGraw, and as our special reporter on the scandals and peccadillos of the London scientific community, Saurabh Jha. We'll see you next week. Next week will not be on Thursday, because I have a lecture I have to do at Columbia Business School. It'll be on Wednesday, same time, Wednesday, 1 p.m. Pacific and 4 p.m. Eastern. And thanks for watching THCB Gang. We'll see you soon.